Today topic of discussion is iron deficiency anemia. Iron deficiency anemia is most common anemia in India and the world, and comparing to other, this one is most common. It prevalence in higher in developing countries. There are two type of iron in heme and non-heme. Heme presented in non-vegetarian diet, that is meat and all, and the non-heme iron is presented in vegetarian diet like green leafy vegetables, the jaggery, they containing iron. Whatever iron we take in diet, there is iron whether have heme or non-heme. It is ferric. Ferric means F3 form. F3 form. Vegetarian and non-vegetarian, it is going to mouth. From the mouth, it is going to esophagus. Then it is going to stomach and intestine. Whenever iron we take in diet, this iron whether have heme or non-heme, it is ferric form, that is Fe3 positive. Vegetarian and non-vegetarian, it is going to mouth. From mouth it is going to esophagus, then it is going to stomach, then it is going to intestine. In intestine, there are the cell here, there are the cells, cells of intestine which will absorb this iron. This cell will absorb iron. Just behind it we have blood vessels. So here we have blood vessels. This is the blood vessels in the submucosa. So we want to absorb this iron from blood vessels so that it can reach to blood vessels. When we are eating, it will reach to blood vessels. Now that iron will come in this intestine. When we are eating, it will reach to intestine. But here that problem is that intestinal cell will absorb only, that intestinal cell absorb only divalent form. Here it will come Fe3 plus. Divalent 2 plus only it will absorb. So this cell, intestinal cells will absorb only divalent molecules, that is ferrous form. Fe2 plus is ferrous form. Before absorbing this iron, must converted Fe3 plus is converted into Fe2 plus. First condition. Ferric form is converted into ferrous form. So basically this conversion is done by HCl. So conversion done by HCl of stomach. So the stomach we have hydrochloric acid, that HCl is converted Fe3 plus into Fe2 positive, that is ferric form to ferrous form. That means trivalent to divalent, then only it get absorbed, then only it will get absorbed. Once it get converted, basically the HCl is required. So for this conversion, HCl is required. So more HCl, here more HCl secretion, more conversion. That means Fe3 plus is converted into Fe2 plus. More is the conversion, more will be observed. So more observation process will happen. So acid is required. For iron absorption, make a note of it. So ultimately Fe2 plus is ultimately formed. So because of this HCl secretion, this Fe3 plus is converted into Fe2 plus. So here with the help of HCl, this ferric is converted into ferrous form. Now this ferrous form is moving to our intestine. Now it is moving to our intestine. Now in this intestine there are two type of transporter. First transporter presented in that luminal surface. So here one transporter, second presented in the this basolateral surface. Here it is presented. First, this luminal surface is known as DMT1. That means divalent metal transporter 1. Divalent metal transporter 1. As the name indicate, it will absorb only divalent molecules, not trivalent. Divalent molecules only it absorbed. That's why we have converted ferric to ferrous form. So that reason only here conversion process, ferric to ferrous form. On the other side we have another transporter. So here we have another transporter which is known as ferro 14 transporter. Ferro 14 transporter. The DMI1 will take iron from lumen. So will take iron from lumen into that cell. So cell. From the cell, this iron, ferro 14, with the help of ferro protein, okay, transport this cell, okay, so to here blood vessels, through blood vessels. Now iron reach to blood. But the ferro 14 again oxidized. So here again it oxidized the iron from ferrous to ferric form. So after transmission, whenever it will reach to blood, it will converted into ferric form. So ultimately in the blood it is ferric only. So through in the for transport purpose only it will converted into ferrous form. After reaching blood it will converted into ferric form. Whenever reaching in the blood the ferric only. So it when it will reach here E3 plus only. For absorption purpose only converted into ferrous form. So ferric to ferrous converted into stomach by HCl, and ferrous to ferric again is converted by second transporter, that is ferro 14. The basolateral transporter. So ultimately it is reached in that blood. It will reach to that blood. Now in the blood iron cannot. Now in the blood iron cannot move above. It required for transport purpose, it required the transporter. So what is the transporter of iron? The transporter of iron is known as transferrin. The transporter of iron name is called as transferrin. It is the transferrin. This transferrin two molecules of iron set. This one is the transferrin, this Y shape. Here two molecules of iron set on. Okay, one molecules of transferrin, two molecules of iron will sit. So one molecule of transferrin, two molecules of iron will sit, and it will carry that iron from everywhere of that body. It will carry iron everywhere in the body throughout the blood. You can say it is that vehicle of that iron. It is a scooter or it is a car of iron. So iron is moving in blood with the help of transferrin. So T for transporter. Transferrin act as a transporter. This Y shape is the transporter. This two things is the iron molecules. Now iron is required in that bone marrow. So now this iron is required in our bone marrow. So it will be carried to that bone marrow via transferrin. So via transferrin it carried to our bone marrow. So whatever iron required in that bone marrow for hemoglobin synthesis, HB synthesis, it required, it will be taken by the normoplast presented inside of that bone marrow. So normoplast required, okay, normoplast presented inside that bone marrow, they will take it and they will synthesis a hemoglobin out of that iron. Whatever extra iron is remaining after that, it will go to that liver. Extra amount of iron will go to that liver, and extra iron will store in the liver in the form of ferritin. So storage form name is called as ferritin. So it is a storage and it is a backup, it is storage form of iron. So this is the summary. What we learned here, we learned that transporter of iron is known as transferrin, storage form name is called as ferritin, and we learned iron is getting converted into ferric to ferrous for absorption, and after absorption from ferrous to ferric again we learned true transporter TMT and ferro14. So it is that complete iron absorption. Now let's talk about regulation of iron absorption. Sometimes what happen, if we eat too much iron in diet, so what will happen, all iron will go and the maximum iron will be accumulate in the liver in the form of ferritin. So here it will accumulate in the form of ferritin. Once the excess of ferritin is there in the liver synthesis protein is known as hebicidin. So excess amount of ferritin presented in our liver synthesis protein, that name is called as hebicidin. So that hebicidin is synthesized by liver, that will come in blood by in blood vessels via blood, it will go to ferro14 and inhibit and degrade that ferroprotein. So this is the function of hebicidin. What is the function of hebicidin? This hebicidin synthesized by our liver, that will come in blood, so it will come to blood. Okay, after that it will go to ferro14 here. So it will inhibit and degraded that ferroprotein. So this is the functions of hebicidin. So more in hebicidin, it will cause more degradation. More amount is presented means it will cause us more degradation of ferroportin. So iron, now you whatever iron you will take in diet, it will go inside. So whenever we will take iron, it will come to inside but not absorbed, it will excreted. Okay, it will excreted in feces. Whenever we will eat, it will come inside but not absorbed, it will excreted in feces. So whatever iron excess is there, that whatever iron excess amount is there, hebicidin will come in the role whenever iron depleted. So the concentration of hebicidin will synthesized by the liver. It depends on that iron that we are taking in the diet and storage form in that iron. If there is more storage, more ferritin and hebicidin will be more. If there is less storage, it will be less. So the complete absorption and this one is the complete absorption and regulation of iron. This one, whenever body excess of iron, the body have assessed that iron more hepcidin will be formed, and less iron absorption, it will inhibit iron absorption. Whenever body have less iron storage, imagine the situation, liver have less ferritin, so liver will not synthesis hepcidin, will fall, and ferroportin again will come in role, and it will increase that absorption. More is hepcidin, less is that absorption. Less hepcidin, more is absorption. So hepcidin is inversely proportional to iron absorption. Hepcidin is less, absorption is more. Next, what are the factors affecting iron absorption? Two type of factors. Factors increasing absorption, this one decreasing absorption. We know that divalent storage increasing that absorption, that means this one. Ferric form is converted into ferrous form. This ferrous form increases absorption. Ferric form will decreases. Then acid HCl in stomach. Then that citrus fruit like lemon containing ascorbic acid, amino acid, sugar, these type of acid converted ferric to ferrous, so it will increase. Then here alkaline food, echinoteria, alkaline food, phytates, tannates, phosphate in diet. These are the factors will decreasing. Alkaline food, pancreatic secretion, that one decreases iron absorption. Then iron deficiency increases. Okay, here hepcidin will come in that role, so iron deficiency will increases, iron overload will decreases. Then physiological condition like pregnancy and hypoxia condition increases. Then here tetracycline, inflammatory disorders, they decreases iron absorptions. What is the etiology of iron deficiency anemia? There can be four things. Either the person is taking less diet, person is taking less iron in the diet, or requirement is more, our body requirement is more, or the blood loss is there, or absorption is less. So they can be the four causes of iron deficiency anemia. Iron deficiency anemia, basically there are three stages. What are the three stages? The first thing, there is storage iron depletion in iron storage form of that iron is depleted. The second one is iron deficiency erythropoiesis, and the third one is frank iron deficiency anemia. First one is the storage iron depletion. Iron go on depleting. All ferritin is also depleted. Either diet is providing iron to that hemoglobin synthesis to that marrow. It is presented from that, coming from that liver. So basically marrow is not getting iron, hemoglobin synthesis. So the marrow erythropoiesis will occur, but it will be iron deficient erythropoiesis. Still patient don't have symptoms of anemia. The microcystic hypochrome RBC are formed, but still patient don't have symptoms. After some times, when the patient have frank symptoms of iron deficiency anemia, it is known as frank iron deficiency anemia. Initially there is depletion in the storage iron. Okay, initially depletion of that storage of iron, then iron deficient erythrophysis. Third one is frank iron deficiency anemia. First stage only serum, first stage, okay, only serum ferritin level is low. First stage serum ferritin level is low. So that's why we can say serum ferritin is the most sensitive and specific marker for iron deficiency anemia. Remaining everything is normal. Remaining everything is normal. Serum ferritin is the most sensitive and specific marker. Second, iron deficiency erythrophysis. Ferritin is still low, but transferrin saturation also decreased, hemoglobin also decreased, microcystic hypochromatic RBC are there. Third one is frank iron deficiency anemia. All the symptoms will come. So these are the three stages of iron deficiency anemia. Clinical features of iron deficiency anemia. The patient will have non-specific symptoms like weakness, fatigue, palpitation, pallor of the skin, mucous membrane, and sclera. Older patient may have angina, ischemic chest pain, okay, angina and conjunctive cardiac failure. Old patient may develop angina and conjunctive cardiac failure. There are some epithelial tissue changes in nail colohysia, then are spoon nailed, okay, that patient nail look like a spoon. Then tongue, atrophic glossy, atrophic glossitis, then mouth angular stomatitis. All the diagram I will attach here later. Then esophagus causing dyspnea, development of development of membranous web at so esophagus causing dyspnea, development of membranous web at here, okay, membranous web at post cricoid area. Name is called Plummer Vision syndrome. It is a triad, iron deficiency anemia, then esophageal web ring like structure will form. After that, dyspnea, difficult to swallow food. So it causes Plummer Wilson syndrome. Iron deficiency anemia. Ferric form is converted into ferrous form. With the help of transporter, it will reach to blood vessels. After that, it will reach to bone marrow. After that, it will reach to liver. Here storage form name is called as ferritin. Then after excess amount of storage is there, means here it will secreted protein. Hepcidin will affected the transporter. So whenever we will eat iron food, it will reach here but not undergo that absorption process. It will excreted in the form of fecus. So all the things will converted into divalent form. After that only observation process will happen. When it will reach to blood vessels, after that ferric form. Then this one is the flowchart format. Then it will accumulated in iron form, storage form in liver, name is called as ferritin. After that, our liver synthesis protein name is called as hepcidin. This one will come via blood, inhibit that ferroportin, that transporter. So increases level means decrease observation, decreases level means increases observation. So what are the factors will affecting iron observation? Then etiological factors. Then 3 stages. Whenever we didn't take iron food for 3 weeks, like that, after that that iron will store in bone marrow and liver. Our body will take iron from liver and bone marrow. Okay, so up to 2 months our body will taking iron from our that bone marrow and liver storage form one. So don't cause us in any symptoms, later only it will cause us symptoms, frank iron deficiency. These are the clinical pictures, these are the symptoms. Angina and conjunctive cardiac failure will cause us to older people. These diagrams, that a spoon shaped nail, how tongue affected, and mouth diagram attached. Clinical picture will discuss next video. Thanks for watching.